as far as, so if we're starting with the back, then we just uncover the low back. Okay? And depending on what they're wearing, either top or double tops. Okay. If you are going from the legs to the back, then we'll train as usual underneath the leg, and then you will go to glutes, and then you actually can go right to the low back from there. Okay, I'm going to start with the low back, and because it's a little chillier, I don't want to keep her undraped for too long. Is that okay with you?
Yes.
And I just really need to get low on the back. I really want to be to the top of the sacrum for my draping. So if somebody is wearing something that's around their waist, you know, like underwear or something like that, ask if you can tuck it and move it down a little bit, because you need to get low on the hips. So you can explain what you're doing and they should be fine with that. Okay. I will say that most of my clients do leave their underwear on, but ladies do remove their bra for the most part. Are you finding that in the studio? So I specifically asked her to disrobe today so that we wouldn't have that encumbrance. So here's her natural waist. So this is where we're going to find QL, right? Yep, the narrowest part, the natural waist. Right below the 12th rib, just above the iliac crest. And as you can see, you just don't have a whole lot of room between the two. Okay, 12th rib is right there. I'm actually touching it. That's the edge of the 12th rib right here. Do you feel that? Mm-hmm. Mm-hmm. So if you want to come around, see, right there's the edge of the 12th rib. And then of course there's the iliac crest. So that's it. That's the room that you have to work in, but it'll be fine. Okay. Everything else from here to here, that's top of the glutes. Okay. But I do want to incorporate that in what I'm doing. Okay. Because this whole fascial system goes all the way down through here and then down and then separates it. Anatomy trains. Did anyone look at that yet? No. Anatomy trains, Thomas Myers.
I pulled up what it's about.
It is. Mm-hmm. So what do we do first? So if you start at the head of the table like this, and you start warming up, going down the back, you can use this as an assessment. You can feel how much the low back is giving as you are pushing towards the feet. And you can also see any raised areas, which I can on her. If I just get nice and low here, and I eye up her spine, I can see that this left side right through here is elevated over the other side. So even if she didn't tell me that she needs left low back work, I would, because I can see that that area is raised, which means there's some kind of imbalance there. Now, I'm not going deep enough to figure out what it is yet, but that's fine. And to be honest, I don't remember what the plaster showed. Do you? I remember that. That was so long ago.
Just stand up, bro. And yeah.
Yeah.
Mark's place.
With your eyes closed. So remember, we're just warming up. And she's fair-skinned, which means she's going to get hyperemic faster. But does that mean that she is warmed up? So I'm using my deep tissue principles. I'm working broad to specific here. I'm even starting to now focus in on this area versus the entire half the back. Do all kinds of stuff to warm up. But this is where I'm going to start getting a little more specific, not just with my warm up, but also with my assessment. Because I know that there's some imbalance here, part of my warm up is going to be figuring out which muscles aren't involved. So I'm working the lumbar erectors here. Just gentle circular friction with my thumbs. I'm not pressing in hardly at all. And you just make it nice and smooth and long, however you like to. And now I'm starting to work a little more laterally. It's just an effleurage, but it's like a level 3. And I'm coming down into the top of the glutes. Again, feeling for restrictions. Trying to put the whole puzzle together in my mind. Figure out what's going on there. What you don't want to do, though, is push right up against the bone, right up against the iliac crest. So you see, my fingers always slide over top. Anytime you run right into a bone, it hurts. Okay. So I'm going to start to focus in a little bit more on that low back. So I'm going to use the ulnar order of my hand. Okay, now that this is generally warmed up, I'm going to just be a little more specific with my warm up. So I'm going to use that sawing kind of motion towards the spine. And I'm not pushing in real hard, am I? But I can push in just a little bit more with each pass. Remember, as you start to get deeper, you start to slow down. Okay, so now I'm kind of in there. See, my hand disappears a little. That's not too bad, right? Nope. So getting that nice and warmed up in there. And unfortunately, this is kind of all you can do because there's not much space if you're warming up QL, right? So not only am I warming up QL, but I'm also warming up those lumbar erectors. And if you want to, now you can come in with sort of reinforced fingers and do a little bit more specific warm up, but I'm still not jabbing my fingers in there. And I'm kind of doing like an ocean wave with my fingers. So I come up and I pull back down. And I come up and I pull back down like a wave on the sea. And it's actually really relaxing, right? Yeah, it's kind of nice. All right, so now I'm in touch with UL right there. Is that okay?
Mm-hmm.
Is that tender at all?
It's a little tender.
You have to see how deep my hands are, though. They're gone. They've disappeared. Okay. But does it feel really deep to you?
It doesn't feel really deep now.
It's because I got in there slowly. I didn't just jam in there. And that's important too as a sensory cue for your client. You're working in, you're working in, you're working in a little bit rather than saying, hey, we're going for QL and then just go right at it. Surprise. Not cool. Okay. So now if I want to be very intentional and very specific on QL, I am going to use that Lego. So I'm going to work my way back in there. And remember that QL is in the middle of their body. So you have psoas on the anterior lumbar vertebrae, and then just behind that, you have QL. So it's deep. So if you are way up here, everybody come take a look. If you're way up here with your thumb placement, you're nowhere near QL. you're on lumbar erectors, the edge of lumbar erectors. Okay. For QL, we're going to be down in here. Okay. So I've got my Lego hand and I'm just kind of gently working back in, and I'm going to reinforce my thumb just because I don't like to use thumbs for deep work, but here I don't really have a whole lot of options. So kind of rocking back and forth, using a little more body weight each time. And right about there. Am I on it?
Yeah.
Is that tender?
A little bit, but not.
Does it refer anywhere?
No.
So I'm as deep as I can possibly get here. I have pushed into her body. Her body has accepted me this far, and I cannot go any further, and I'm not going to jam any further. This is where you really have to focus your mind's eye into your fingers and visualize inside the body. What am I next to here? Okay, so there's the edge of QL. And I can just gently rock on that. If there is a trigger point here, I can use static compression. We can breathe. And then we gently come out. Now remember, when you're in there, you do have to keep your thumbs in a C shape. If that's too much or too hard on your thumbs, no problem. You can just go back in the way you were before. Okay, putting the backs of your hands together and using reinforced fingers. Okay. I'll show you another way to do it a little bit later. Now, lumbar erector. So her issue does not appear to be QL. Her issue appears to be lumbar erectors. How does that feel right in there?
That's more tender.
Yeah. So remember, from here to here, that's lumbar erectors. They're very thick down in the lumbar area because you have the thoracolumbar fascia here too. The 3 layers of erectors, the transversospinalis group, like you just a lot of things converging there. Plus you have the abs. Remember, they come all the way around to the back here. So a lot of tissue in here. So you're going to feel, it's going to feel pretty thick through here. But it feels a little hard right about there. Is that can confirm?
Yes.
Yes, can confirm. So I can actually do the exact same thing that I did for QL. I can use my fingers, or I can use my thumb, or I can come back in with the ulnar border. And I can just work a little bit deeper across all those layers. What I'm not going to do, though, is I'm not going to stick my elbow anywhere near this area. Anyone know why? What? It is a smaller area. What else? It's a caution area. Why? Yeah, because of the floating ribs and the spine. Kidneys are a little higher, but still. Yeah, that too. Still want to stick an elbow back here. Okay. I'm just making some space in here. See, work in here for a little bit. It tends to go right in through here, right in through here. Ooh,
Yeah.
there it is. So erectors do twang, right? You felt on people, you go across them, they feel a little bit like guitar strings, but you get to a point, right? Ooh, and you go, that doesn't feel like the rest of it. That's thicker. Oh yeah, right there. That's thicker. That's called a jump sign. When you get on something and they twitch or jump or move away, that's a jump sign, and back off. Okay. So I would want to work more specifically in here. And I'm going to start with broader tools. I want to really warm that area up because obviously when I went in with fingertips, it was too much. Okay. I may work from the same side. I may decide that I want to do work from the opposite side. Either way, though, I'm not putting an elbow in there because now we're close to the kidneys. Okay. So I can take the edge of it and I can push towards the spine, like the spine's my bolster. Oop, right there. Okay. Gonna push towards the spine a little bit. Take a couple deep breaths. There we go. Nice big breath. Softened a little bit. Erectors are tricky though. You could be on these for an hour and still not make a huge difference. So you just have to pick when it is time to move on sometimes. And I'm going to move on because we have limited time. But you might come back in and in this area, or you might suggest that she come back specifically to work on that. All right, so we're going to transition to the glutes. So I'm going to do a redrape here. Lift under the knee, remember, just very gently and pull up, pull up towards the hip. Okay, and she actually has quite a bit more here. So if we were going to go through the sheet, then this is all we would need to do. And a lot of people are going to be more comfortable working through the sheet. Okay. I did ask her to disrobe. I'm going to show you what that looks like. So all you do is just pull this, roll this back like this, okay, to the gluteal fold and no further. You do not tuck it in the gluteal fold. Y'all laugh, but I have to say it for a reason. Yes. I have to say it for a reason. Okay. Anyhow, yeah. Anyhow, you aren't as mortified, but I know. Y'all, yeah. Anyway, this will stay just like it is. So you don't need to do an additional tuck. If your client feels more comfortable with an additional tuck, you may ask, or, you know, a belly tuck. Or sometimes you can just do that, okay, to hold the drape in place. But because it's tight up to the hip and because you rolled it backwards, it's not gonna. Okay. So we're gonna put that back. Just for her modesty, because, you know, you all are staring at her. Start in with some glute work. And also because you're going to be working through the sheet mostly. So I want to demo through the sheet. So you notice I start with big tools on the glutes. I know you have a Swedish routine that you do. A bit of petrissage. Yeah, that's right. I actually do that on the low back with my palm heels. Yeah. And again, this is also assessment. So every stroke that I do here, I'm feeling for areas of tension where it is not letting me in or where it feels different. Not too bad. I can also work on the side a little bit, but notice I'm not doing this to work the side. I'm sure some of you will, because I watched you do it like throughout NMT. Getting really close to your work. You don't have to. In fact, you don't even really have to look. You are in that stage. So you have a nice warm up here. I can feel the bony landmark, so I'm up against the sacrum here with this side of my hand over here. And that sciatic notch right about there. Work this way. Feel the greater trochanter right there. Okay. So if the sacrum is here and the greater trochanter is here, then piriformis is right in between the two, right? Okay. Sacrum is here, greater trochanter is here. You just draw a line, and right in the middle is piriformis. Okay. Sometimes books have you do a T shape, and you're right along there. Okay. But either way, you do need to find those bony landmarks. And then if you just join your fingers, that's it, right in the middle. Now, remember I said we need to work towards the opposite foot because we're working transverse to piriformis. Since it goes this way, we are going this way. And I'm doing another one of those sort of wave strokes, where I'm going across and pulling back, and across and pulling back. A little bit right here. Is that tender?
Yeah.
I would not be able to feel that if I wasn't working transverse to that. Right in, yeah, right in through here. Now this can be the treatment stroke too, but it's not. So I have other things to show you. So we're going to do piriformis pin and stretch. So notice I'm using a sort of wide tool. So I'm using my fist, okay? I'm gonna pin down the piriformis. Now, which way does the piriformis rotate? What? Laterally, right. So to stretch it, which direction do we have to go? Medially, right. So which way is that? This way? No, it's this way. It's this way. It's a lot weirder when they're on the table.
And that's the hip joint, right?
Yes, the hip. I'm just using the lower leg as a fulcrum here. Pin and stretch. Pin, stretch. Do not do if they've had hip replacement. And stretch, we say that, yes, the rotation. But no, you don't have to. It's just a nice stroke. Now, if any one point in here was more tender than the others, we could do trigger point. Is any one point more tender than the other?
Yeah.
Right there?
Yeah.
Okay. This time we get to use our elbows. So I'm going to put my elbow where my fingers are. Get comfy, because this is a decent squat. Okay. Now I'm going to sink down in. Take a deep breath for me. And exhale. And I'm going to sink down into a certain point. And is that okay for you?
Yeah.
And then I'm going to externally rotate. Because when I do this, right about here, piriformis comes up to meet my elbow. And then I don't have to sink down any harder. Is that okay?
Yes.
Are we at a 7?
Maybe like a 5.
Let me know when that decreases.
Softer.
Is it decreasing?
Yeah.
And then remember you come out. So that's a really nice treatment stroke for piriformis. It also, when you do that with the hip, you can feel piriformis come up to neutral elbow, which also means you don't have to push so hard into the ball. Okay. Now glutes are pretty good, actually. Piriformis was a little hypertonic, but if we want to get into gluteus medius, we need to come in from the side. Now, this is not my favorite position for gluteus medius, but if I'm short on time, then this is how I do it. And you do want to stabilize the low back if you're going to go in to gluteus medius, and sometimes I'll use my hip to bolster my elbow, so I use my body weight instead of my strength. Because otherwise, I'm way down here, and I'm still using body weight, but it takes me a lot more. It uses a lot more shoulder. I don't want to do that. So I'll bolster my elbow with my hip. That's not too bad. Is that tender?
It's a little, it's guarding, so.
Oh, okay. There.
Yeah.
So this is a good place for knuckles, because you want to be able to get in between the iliac crest and the greater trochanter, and half of that is tendon. So you want something wide, but also something a little more specific than just a fist. Like right in through there. Yeah. Remember, myotendinous junction and muscle bellies are good spots for the points. Do a little circular friction with those knuckles. And as you work a little more anterior, you are on TFL. Like I said, though, this is not my favorite way to address gluteus medius, just because you really have to be in kind of a deep squat to do it. While you're in this position, you can also get the upper portion of hamstrings. You can get right at the gluteal tuberosity, or not gluteal tuberosity, ischial tuberosity. Thank you, Brent. Right in through there. So you can make a nice little session just with low back and hips. You know, you haven't even turned her over yet. Okay. All right, so one more thing I'm going to show you. Take the bolster. You lift your legs first. Okay. I'm going to put her in a little tent here, and will you please roll on your side facing? It's the only thing wrong with the tent. I can't tell. All right. So I'm actually gonna, are you comfortable like that? Doesn't look comfortable, but okay. All right, so sideline is a really great way to get into QL, gluteus medius, TFL, and iliopsoas all at the same time. So if you're doing a low back and hip session, or if you are doing a lower cross syndrome session, you may want to think about sideline. So I'm going to show you how much easier it is to get into the QL in this position, because here's her iliac crest, which is much easier to find in this position. Our 12th rib is right there. My fingers are in the only place they can be. And there we are. Is that okay? Mm-hmm. Does that feel less intense?
It does.
Yeah. The sideline position just in general is less intense for QL. It's actually a little more intense for gluteus medius, but for QL, it's a lot easier. And you as a therapist can feel QL a lot easier in sideline position too. So it was much easier for me to find than to like go through the layers on the anterior side. There it is, right there. Okay. And I can work it just like that. Remember the little wave shape. You can do that from the side and it feels really nice. You can also do a little cross-handed stretch. Try to make some room in there. Also feels pretty nice. And then if I want to get into gluteus medius, see, this is brilliant because there's gluteus medius. I put my hand here. Your greater trochanter's down there. My hands are too small, but you get the idea. The fibers go like this. So you know exactly where that is. And I can work transverse to those fibers too, because they go in different directions. Can do some palm heel. Does that feel nicer than when you were on?
Yeah.
Yeah. I can get a little bit deeper without as much effort. And I can really feel the fibers a lot more in this position. I can feel their direction versus trying to push in from the side. It's just not as effective. But like I said, if you don't have a lot of time to put your client in sideline position and roll them around, don't worry about it. So in this position, you can get trigger points too. When they are prone, it's a lot harder. You don't want to be going in from the side with your elbow. You basically have to use thumbs or knuckles. See, doesn't that feel better? I was like, what? Uh-huh. I'll give you till tomorrow to say. And then just here, you have the ASIS, just posterior to the ASIS, little TFL. They can really isolate TFL in this position too. Okay. But, you know, we want to do the cross. We want to get those tight muscles first. So in this position, remember, ASIS, yes, you know, that one. The ASIS is here. We can have our client take a deep breath and curl our fingers in. Curl our fingers in right here, and we're on iliopsoas. Okay, and we can do the same kind of back and forth motion that we did when we had our client supine. Yes.
We wouldn't do it right close.
You can, but you can't do as much just because of draping constraints. But you can have your client move their leg posteriorly, right? You can ask them to actively extend it with your fingers in here. It's kind of like a pin and stretch. And there are other things that you can do too with the drape, but this is good for now. Can't show you all the tools. We need to save some for some of these. All right. Yeah, so that's not too bad, right? Like these are all a little bit less intense than their supine or prone versions, just because you don't have to press in as hard. I do want you to try both versions. I want you to try the prone and I want you to try the sideline. See which one feels better to your client, see which one you like best, and also just for practice. Okay? Any questions? All right. Thank you.